Okay, sorry about that. All right, so going back to the high-risk registry, we have additional risk factors after a neonatal period into infancy, and that includes parental concern regarding hearing and speech. So if a parent is ever concerned that the child is not hearing, say, or speaking at the same level of, say, its older brother or its cousin, the pediatrician or the teacher or you as a speech pathologist or audiologist should take this very seriously. If a parent, a parent's with the child most of the day, so if a parent thinks that there's something going on, you should certainly follow up on that. Bacterial meningitis, again, it's an infection of the meninges and the spinal cord in the brain. It can happen at any time, so it's still a risk factor. Head trauma, a stigmata associated with the syndrome, ototoxic medications, and recurrent or persistent ear infections for at least 2 months. So all of these could cause any type or degree of hearing loss, bilateral or unilateral. All of that is going to affect speech and language development, so you should be aware of all these risk factors. Even if it's just a transient conductive hearing loss, like ear infections, numerous ear infections can delay speech and language development. Okay, so infants that pass the initial hearing screening but have one of the risk factors are periodically monitored. They have their hearing tested every 3 to 6 months until they're about 3 years of age, and the risk factors for delayed onset sensory neural hearing loss include some genetic conditions, a family history, uterine infections, and some neurodegenerative disorders. With a conductive hearing loss, like I said, recurrent or persistent otitis media, that's an ear infection with effusion, with fluid in the middle ear, anatomic deformities, and other disorders that affect the eustachian tube, and neurodegenerative disorders. ASHA recommends that children at risk for hearing loss undergo ongoing attempts at diagnosis the first 3 months of life. You should inform the parents. I think it's very easy for us as speech-language pathologists and audiologists to take for granted how much we know and assume that, why doesn't everyone know that a hearing loss would cause a language delay? But, this is our field, this is our specialty, and other people have other fields and other specialties, and you need to inform them and educate them about hearing loss and speech and language development and delays. Children might be evaluated by ABRs, and we just need to follow up with them and stay on top of it. So newborn hearing screening can be done 2 ways. Remember, this is just a screen, so it's not a full diagnostic evaluation. If the infant fails the screen, then the infant will come back for a full diagnostic evaluation. And the full diagnostic evaluation, which would confirm a hearing loss, would be an ABR, an auditory brainstem response. So we learned about that about 1 chapter ago. But there's also a version of an ABR screen, and there's an otoacoustic emission screen. So an infant is either screened using an ABR screen or an OAE screen. If the infant fails the screen, then the infant has to come back for a full diagnostic ABR. So nothing is perfect. We don't have sufficient norms for high-risk babies with the ABR. ABR isn't a true test of hearing. It's a test of the synchronous neural firings in response to acoustic stimulus. So at the end of the day, a child could have normal OAEs and a normal ABR and, normal middle ears and never speak. The auditory cortex needs to understand language and the brain has to be able to respond. So until I say, "Come here, Billy," and Billy looks up and crawls to me. I can't be sure that a child has hearing, that their brain is making sense of hearing. Do you understand what I mean? To really hear, you have to understand a message and respond appropriately. But, ABR is pretty great that I can test the neural firings of acoustic stimuli. The problem with ABR is the equipment is costly, but remember I said that it's, in the long run, it's totally worth it, so it's done. ABR is, to remind you, measure the electrical response of the brain evoked from an auditory stimulus. So there are electrodes placed on the brain. You could watch, not on the brain, on the infant's head. You could watch the video. And sounds going click, 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 click. We send the sounds in through the earphones. We measure the response of the waves on the computer. With the ABR screen, we're looking for a hearing. We're looking for a hearing. We're not looking for a neurodegenerative disorder. So going back to our last chapter, ABRs can be used for two things. One, to find a hearing threshold, and the other to find if there's an acoustic neuroma or some sort of growth or something wrong with the auditory nerve. In this case, we're just looking for the threshold. So we put the electrodes on the baby, we present our clicks very fast, and because we're looking at a threshold, we're looking for the fifth wave, the last wave of the ABR, to be present. So with the screen, this isn't a threshold search test, so this is a screen. So there's only one level of sound put in, 40 decibels. 40 decibels is about normal conversation level. So 40 decibels is put in. If you can see a wave 5 at 40 decibels, then the audiologist can assume that the infant has no worse than a 20 dB mild hearing loss. So it's a screen at one level. You put in 40 decibels of sound. If you can see wave 5, then the audiologist can assume that the infant has no worse than a 20 dB mild hearing loss. So like I said, we're looking ABRs. They cover from 1,000 to 4,000 hertz. You're looking at wave 5, its latency, its time, its amplitude, and the last part at which it disappears. The closer the level is, the auditory stimulus, for example, the 40 decibels, is to a person's threshold, the longer the latency and the weaker the amplitude it's going to be. ABRs are a bit more expensive than OAEs, so OAEs may be used instead. If you remember, OAEs are a test of cochlear function. Infants that have OAEs, you can assume they have no worse than a 35 decibel hearing loss. Infants that fail the OAE screen are referred for a full diagnostic ABR. The issue with the OAEs is any fluid in the middle ear is going to be a problem, and infants are born with fluid in their middle ears. So an infant is more likely to fail an OAE an hour or two after birth than 48 hours after birth, because 48 hours after birth, the infant has more time to get the fluid out of their ears, to drain the fluid. So OAEs, the problem with OAEs, there are a few problems. One, you have to send the sound in through the middle ear to the cochlea, and then the response that occurs in the cochlea has to also travel back out through the middle ear to be recorded, as opposed to ABR where the response is recorded on the scalp. So with an ABR, the sound goes in through the cochlea, in through the middle ear, to the cochlea, up, and it's recorded from the electrodes. With the OAE, it's got to go in and out through the middle ear, and any fluid is going to affect the test results. Another issue with OAEs is that it only tests the hair cells in the cochlea, so it only tests up to the cochlea. So the question is, what happens if the child doesn't have an auditory nerve? The child's going to be deaf, but we wouldn't know that because the OAEs only test up to the cochlea. So we don't know if there's a lesion existent retrocochlear or if there's a lesion past the cochlea. the OAE would still come out normal. But it's faster than an ABR and it's cheaper than an ABR. And cochlear hearing loss is much, much, much more common than an auditory nerve hearing loss. Okay, so before we start early intervention, let me just go back to the ABR and the OAEs. So there are two options that hospitals have. They can either do an OAE screen or they could do an ABR screen. If the child fails either an OAE screen or an ABR screen, the child is referred for a full diagnostic ABR. And the infant has to come back with its parents, and it's going to get a full ABR where the audiologist will start at a level of 70 dB and she'll do a threshold search. If she gets no response at 70 dB, she'll go up to 90 dB. If she gets no response at 90 dB, it can be assumed that the child is deaf. So if the infant fails the ABR screen at 40 decibels or the OAE screen, the infant returns for a full diagnostic evaluation where the audiologist will do a full ABR and will search for thresholds in each ear. So the goal of we have early intervention now. We have our birth admission of hearing screening. We have follow-up and diagnostic evaluations for the infants that fail. And we have this idea of getting treatment started at 6 months. 1-3-6. Remember that number, the 1-3-6 model. We want all infants screened by 1 month. We want full diagnosis by 3 months, and we want treatment to begin by 6 months or earlier. So 1-3-6. Screening, diagnosis, treatment. With early intervention, the number one reason that infants, toddlers, children see audiologists is to rule out hearing loss as a cause of language delay. So, rule out hearing loss as a cause of language delay or for repeated bouts of ear infections. It's the most common reason that an audiologist are going to see children. So, ASHA has some guidelines for pediatric hearing assessment. This is after newborn hearing screening, fast forward a few months. We have behavioral observation, case history and parental reports, physiological development, and we can still use our OAEs and our tympanometry. When you're evaluating a child, you would use otoscopy and look in the child's ears, OAEs, and tympanometry, but only after like 6 months, maybe even 8 months. So infants, they're very soft and their ears are very cartilaginous. So it's hard to get a tympanometric seal on an infant. That's why we can't use tympanometry on infants, because it's hard to get a seal. Their ear canals are so soft. You can do acoustic reflexes if you can get a seal, pure tone audiometry, and bone conduction if the child is old enough. Our objective tests, like I said, we have tympanometry, OAEs, and ABRs. When you're testing a child, there are always going to be 2 audiologists needed, one to distract the child and one to perform the test. OAEs, ABRs, sometimes it can be hard to get a good response. If an infant is crying or vocalizing or there's a background noise, it's going to be hard to get a valid response. Remember, for tympanometry, OAEs, ABRs, these objective tests where the child isn't involved, the child has to be quiet. And sometimes these tests can be scary. So kids get scared of the doctor. They think they're going to give them a shot. So, if you put something near their ear, even though these probes are nothing, they don't hurt at all, it might upset a child. So Once the child's upset, then it's impossible to get a good test. So when you're testing a child, we're past the newborn hearing screening phase. When you're testing a child, birth to 2 years, it's important to first observe the child, their relationship with their adults, how they walk, how they stand, their motor performance. So in the waiting room, just kind of observe the child a little bit and see what's going on. You also want to see what their communication mode is. How do they signal to their parent that they want something? Is there another child in the waiting room that's doing all the talking for them, like an older sibling? Or are they bilingual? All of that stuff is going to help you put together the picture for what you're doing. Children with high frequency hearing losses, you can use toys and noisemakers and bells and rattles and see if the child responds. If they respond, even though it's, very subjective, it's still a good sign. So, if you bang a pot over an infant and the infant wakes up and cries, that's a good sign. But the stress is made on using meaningful sounds. And like I said, when we're testing children, we have 2 clinicians. One clinician will be in the booth with the parent and the child to distract the child and keep the child happy. And then the other audiologist will be actually performing the test. Once the child is able to localize, then we're able to better test them. So localization is the idea of turning or orienting to a sound, and it's very important for our pediatric testing. So around 6 months, you could really start to do localization tests. Before that age, birth to 6 months, the only valid tests that we have are objective tests. So before objective tests, before OAEIS and ABRs, for infants from 0 to 6 months, they were kind of just tested through observation or through their activity state, their behavioral observation audiometry. So an audiologist would present a sound and then look for a response. And unfortunately, when you're that young, all of your responses are pretty much reflexive, or that shouldn't say voluntary, I should say involuntary. You don't have control. An infant doesn't really have much control over their body at that age. So the test is totally subjective, and it relies on the audiologist's perspective. And, we're all human. We all want an infant to not have hearing loss. So behavioral observation audiometry is not a valid test. We have OAEIS and we have ABRs. However, like I said before, if you bang a pot over an infant's head and it wakes up and starts to cry, that's not a bad thing. That would be behavioral observation audiometry. But with infants from 0 to 6 months, the most effective thing to do is OAEIS or ABRs. Here are some of the responses. Like I said, it's all very subjective. So from 6 months onward, once a child gains control of their head turn, we can do sound field audiometry. Sound field audiometry uses 1 or 2 speakers. So sound field means that the infant isn't wearing headphones. It's not like you're testing the left ear and then you're testing the right ear. When you're testing in sound fields, you're testing both ears at the same time. You're just looking for a response, and you're assuming that at least one ear, if you get a response, you can assume that at least one ear is okay. So there are different sounds that we could use, narrow band, so instead of pure tones, we use more interesting sounds to get the child's attention. The responses to sound is significant. So if I put a sound on and the child looks for the sound, that's good. A lack of response isn't necessarily meaningful. Over the summer, I was in the clinic and I was testing he's probably 4 or 5 years old, a boy that didn't have any language. He was probably autistic. He didn't have language. And, we were trying to do a hearing test in him. We were trying to get meaningful responses, and his dad was tired and exhausted, and the audiologists, the students that were there with me, we were all getting frustrated. We couldn't get any response. We couldn't get the child to focus. We couldn't get him to look when he was supposed to look, or respond in any meaningful manner. But what I did do, say his name was Jacob, I went into the booth with the testing equipment, and I just said his name. I said, Jacob, and I sent it at 20 decibels. And he looked up. He looked up to see where the voice was coming from. So that was a meaningful response, because I said his name, and he looked up. He understood the meaning behind his name, and he wondered where the voice came from. So that was, the best we could do. We got a response, a meaningful response. All the other tests that we had done where we hadn't gotten any lack of response wasn't necessarily meaningful. It's just he was, more interested in doing other things. So to do these tests in sound field, basically a child has to have peripheral vision, and they look at the speaker. They localize to a sound. It's called visual reinforcement audiometry. You can watch the video in our links. So like I said, the child is seated on the parent's lap, and the child is facing an audiologist. And then there's the other audiologist in the booth running the show. And the child's response to a stimuli is visually rewarded. So the child is conditioned to turn to a light or a toy when a sound is heard. And there are these light boxes. I'm not sure if any of you have had the opportunity to observe children, but in sound field, in one or two corners of the booth, the audiology booth, there'll be a toy and a light box. And it's like this fun thing for an infant to look at. So the child is first taught to, when a sound comes through the booth, this box lights up and the pair dances. Okay, so the child is conditioned that when there's a sound, there's this light box. We use narrowband noise because it's more exciting. So you would start at a level that you think the child can hear, for example, 60 decibels, and you would present the tone and the light together. So they start to associate that the tone and the light comes together. And then, once the child understands what's going on, you would just present the sound. And if the child looks to the light box, because they heard the sound and they look up, they want to see the light box, then you put the light box on. But only if they look for where the light box is. Okay, so that's why there are two audiologists. So one audiologist is sitting in the booth, maybe blowing bubbles, quietly distracting the child. The sound comes on through the booth. The child looks up for the sound. They're stimulated with the box. So that's visual reinforcement audiometry. So you're looking for a response. What we're going to test, what we're most interested in are always those speech frequencies. So we want 1,000 hertz. We want to find out 2,000 hertz, 500 hertz, 4,000 hertz. We want to get their minimum response level. Remember, we're not necessarily sure if this is the lowest level that the child can hear, but it's the lowest level that we're getting a consistent response. And because we're testing in sound field, that means we're not testing each ear specifically. We're testing both ears. Basically, we just want to see at least one ear has to be hearing the sound in order for the infant to turn and respond to it. To get the speech detection threshold, we can use babbling or music. So this could also be the music awareness threshold. So again, the audiologist is sitting with the child is quietly distracted, and the second audiologist in running the show puts on music, kids' music, and she slowly raises the volume from 0 decibels to 5 decibels to 10 decibels. And the point where the infant hears the sound and looks up, that would be their speech detection threshold or their music awareness threshold. Okay. So around 18 months, you could try to do more speech testing with the child. And again, it's play for the child. Everything is supposed to be play. So I could say through the booth, point to your nose. And if the infant points to their nose, I could take that they heard and they understand that. Or, you know, where's your mommy? And have the infant respond that their mommy's behind them. Something like that. So I can better study their speech understanding. But the infant, the child, the toddler, the early childhood have to be a bit older for this to work. So speech audiometry isn't necessarily tested formally for a very young child. I could say stuff like, can you hear me? I could whisper, and if the infant says yeah, or the child says yes, it's a good sign. That's all done informally. Pure tone audiometry, as the child gets older, you might be able to get them to participate in pure tone audiometry with you, but it has to be fun. It has to be fun, and you have to be engaging to get a child to fully cooperate with the test. Sometimes you have to be a smart audiologist because, children want to please. So you have to make sure you're getting a valid test, and that you're not getting a child just raising their hand over and over again because every time they raise your hand, you applaud them.